Have you ever stared at a lab report for your horse, or maybe even one for yourself, and felt like you needed, I don't know, a decoder ring just to figure out the abbreviations? It can definitely feel like a secret code sometimes. Well, today we're going to crack one of those fascinating codes. We're taking a deep dive into ALP, or alkaline phosphatase, specifically in our equine friends. ALP is a really common thing you see on those routine blood biochemistry panels your vet runs. You know the ones. But the story behind that number, it's actually far more complex than just, a tick mark on a page. So our mission in this deep dive is to unpack what ALP actually is, where it comes from in a horse's body, why its levels can swing so, well, dramatically, and maybe most importantly, what those changes really mean for a horse's health. You're going to find out pretty quickly that interpreting ALP isn't always straightforward because it comes from multiple places, and there's some pretty wild age-related variations. It makes it a truly nuanced marker.
That's absolutely spot on. It's a perfect example of how one single lab value, while definitely important, it really demands a holistic view. You just can't look at ALP in isolation. You absolutely have to factor in the horse's age, their specific clinical signs, and frankly, everything else on that blood report to really piece together the whole picture.
That makes so much sense. It's kind of like getting one piece of a jigsaw puzzle, right? You need all the other pieces to actually see what you're looking at.
Yeah.
So let's start with that first piece then. What exactly is alkaline phosphatase?
Well, at its core, ALP is an enzyme. Think of enzymes as tiny biological tools that speed up specific chemical reactions in the body. ALP is involved in various metabolic processes, specifically in what we call dephosphorylation reactions. Basically, it helps remove phosphate groups from molecules. That's a really fundamental step in lots of energy and building processes. But its main diagnostic use, when we see it on a serum blood test, is as a marker for cholestasis.
Okay, cholestasis. Let's pause there. For anyone new to that term, what exactly does that mean?
Right, good question. Cholestasis simply means impaired bile flow. So bile isn't moving effectively from the liver where it's made down into the intestines where it needs to go. Think of it like a traffic jam in the liver's drainage system. Now, back to ALP itself. What's fascinating is that there isn't just one type. There are actually two main genes that produce distinct ALP isoenzymes, sort of different versions of the enzyme. There's intestinal ALP and what we call tissue-unspecific ALP. And while that tissue-unspecific kind is found pretty broadly, the equine kidney actually expresses both types. Interesting, huh? These enzymes then get processed further, almost like being tagged with specific chemical labels, especially through something called glycosylation. This tagging creates different forms or isoforms of ALP that are specific to certain tissues like bone or liver. And it also influences how long they stick around in the bloodstream. That's their half-life.
So it's not just one single thing then, right? It comes from different places. And those sort of tags dictate where it ends up. Which sources are the most important for what we actually see in blood tests? Because I imagine if it's in all those places, not all of them contribute equally to what we measure.
Exactly right. While you do find high concentrations of ALP in tissues like the kidney, intestine, liver, and bone, and even lower amounts in places like the placenta, what you see in a serum blood sample tells a slightly different story. Critically, the ALP produced by the kidneys, it's not actually released into the blood, so that's out. And intestinal ALP, surprisingly, has a very, very short half-life, only about 8 minutes.
8 minutes, wow. That's incredibly fast.
It is. It means it clears out of the bloodstream almost immediately, so that really limits its clinical utility for diagnosing, say, acute intestinal issues. Unless the damage is incredibly severe and ongoing, you probably won't see much of a bump from the gut. So the vast majority of what we measure in a serum sample, it comes from two main places, the liver and, to a lesser extent, the bone. The overall half-life of ALP in horses, while it's shorter than in some other species, it's definitely longer than an enzyme like SDH. This means ALP can reflect changes in the body over several days, maybe even weeks. Gives us a bit of a broader picture.
Okay, that makes sense. And how does the liver ALP specifically get into the blood when there's an issue? Is it just sort of leaking out, or is there something more active happening?
That's a great question because it's not simply a leak. No, liver ALP activity is actually highest on what's called the biliary canalicular membrane of the hepatocytes. Those are the main liver cells. Think of this membrane as the exit gate for bile leaving the liver cell. So when there's a problem, increased ALP activity in the blood happens because of one of two main things. Either there's an increased synthesis of the enzyme, the liver cells are actively making more of it, kind of like an alarm signal, or it's released directly from that cell membrane into the bloodstream. The proposed mechanisms for how it gets released are quite interesting, actually. It could be the solubilization of that membrane by excess bile salts that are backing up, or maybe the release of tiny membrane fragments that break off, or even something called biliary regurgitation, which is when bile flows backward because of a blockage. And there's also a specific serum phospholipase, another enzyme, that contributes by literally cleaving the ALP off the membrane, helping it get into the bloodstream. So it's, a dynamic, multifaceted process, not just passive spillage.
Huh. That's a really fascinating look at where it comes from and how it gets into circulation. But I think what everyone really wants to know is, why would this number be elevated? What's the main reason we see those spikes on a horse's blood test?
The main driver, without a doubt, is cholestasis, that impaired bile flow we talked about earlier. Cholestasis leads to pretty significant increases in serum ALP concentrations. It's really important to remember that hepatocellular injury alone, so just damage to the liver cells without that bile flow obstruction, it actually has very little effect on ALP levels, surprisingly. For example, studies have shown that if you deliberately cause a bile duct obstruction in a horse, ALP levels can nearly triple within just 10 days. We also see ALP rise with something called biliary hyperplasia, where the bile ducts themselves increase in number or size, maybe as the body tries to compensate. And because increased ALP often involves enzyme induction, meaning the liver is stimulated to produce more of it, the actual rise in serum ALP in, say, acute obstructive icterus might actually lag behind other important markers. Things like conjugated bilirubin and bile salts might go up first.
Oh, that's a crucial detail, that lag. Okay. So if it's mainly liver and bone contributing to the serum levels, let's talk about the specific systems where we actually see these increases. Where in the body are we typically looking when ALP is high?
Certainly. So in the hepatobiliary system, that's your liver and bile ducts, increases are very strongly associated with cholestasis. That's number one. In the musculoskeletal system, elevated ALP points towards increased osteoblastic activity. Those are the bone-forming cells. So if a horse is growing rapidly or healing a fracture or has certain types of bone disease, you'll likely see ALP go up from that. In the gastrointestinal system, really severe GI disease can sometimes be associated with mild increases. Though, honestly, the precise source in those cases is often a bit unclear. Probably not a major contributor usually. The reproductive system can also play a role. We see placental increases during pregnancy, and importantly, semen ALP comes mainly from the epididymis and testes. Actually, a high semen ALP level with few or no sperm can help confirm decreased sperm production versus, say, a physical blockage or ejaculatory failure. That's a key distinction for breeding soundness exams.
Huh. That's interesting about the semen ALP.
Yeah. And finally, in the hematopoietic system, which involves blood cell production, severe anemia, things like equine infectious anemia or red maple leaf toxicity, onion toxicity, even significant blood loss after foaling. That can lead to hypoxic injury and swelling of liver cells. That results in a secondary cholestasis, which then bumps up the ALP. We can also sometimes see elevations with certain blood cancers like hepatic lymphoma or leukemias, although those are rarer.
Wow. Okay. That brings us to something I've often heard that sounds completely counterintuitive, especially for owners: foals. I've heard foals can have ALP levels that would make any adult horse owner absolutely panic, but it's completely normal for them. What's the science behind that incredible age-related variation?
Yes. It's honestly one of the most important things to understand about ALP in horses. In neonates and young foals, ALP activity at just 1 to 3 days old can be up to 20-fold above normal adult levels.
20 times.
20 times. It's truly amazing. I remember seeing a lab report for a perfectly healthy, bouncing foal with an ALP level that, if it were an adult horse, you'd be thinking emergency intervention. These really high values then gradually decrease. They get down to maybe less than 5 to 10 times adult levels by about 2 weeks of age. And then they continue to taper down, usually reaching adult concentrations by 6 months to maybe a year old, sometimes a bit later, perhaps around 15 months. And here's the truly surprising fact. Extremely high levels, sometimes even over 1100 UL in foals around 11 weeks of age, can be completely, totally normal. This is sometimes called idiopathic benign ALP elevation of foals, and it's absolutely not associated with disease. It's just them being foals. It reflects all that active bone growth happening.
That's incredible. So idiopathic benign ALP elevation. Good term to know.
Definitely. Now, for pregnancy, the impact on serum ALP concentration in the mare herself is kind of equivocal. It doesn't always go up just because she's pregnant. However, it is worth noting that some diseases that do cause cholestasis and increased ALP, things like hyperlipemia or Thaler's disease, they seem to be more common in pregnant mares. So you might see elevated ALP for that reason. And for certain breeds, especially ponies and donkeys, they are particularly susceptible to conditions like hyperlipemia and hepatic lipidosis, fatty liver disease, which definitely can lead to high ALP levels.
Right. The ponies and donkeys are prone to that. That idiopathic benign elevation in foals is definitely an aha moment for many listeners, I bet. So beyond that normal age-related growth in young horses, what are the most common disease-related causes of elevated ALP? What are the main buckets we tend to see in practice?
Okay, so setting aside the normal physiological growth in foals, which is probably the most common reason overall for high ALP in young animals, we mostly look at disease processes. The biggest category is definitely liver disease, especially conditions that involve cholestasis or chronic liver injury. This includes things like chronic biliary obstructive liver pathology, maybe chronic pyrrolizidine alkaloid toxicity from eating plants like ragwort senecio species. Also, inflammatory conditions of the bile ducts like cholangitis or cholangiohepatitis, and hepatic lipidosis or fatty liver, which, as we mentioned, is especially common in ponies and miniature horses. That's another key one in this category. Beyond those sort of primary liver issues, we can also see elevations from metabolic problems. Things like hyperlipemia, often triggered by anorexia or fasting, and severe anemia, as we discussed, can indirectly lead to liver changes and cholestasis. Immune-mediated or infectious conditions are another bucket. Think chronic active hepatitis, Thaler's disease, or even broader systemic infections like endotoxemia, which you might see with severe colic that can affect the liver, and of course, toxic exposures. Whether it's from plants like Senecio, Crotalaria, Alsike clover, or mycotoxins in feed like aflatoxin, or even certain chemical toxins and some anesthetics like halothane was known to cause issues. Those are always possibilities. In adult horses, bone metabolism abnormalities that cause increased osteoblastic activity beyond just normal turnover can indicate conditions like osteoporosis, osteomalacia, or even healing fractures. Those can bump ALP up mildly. And finally, sometimes severe gastrointestinal disease can cause mild increases. But again, because of ALP's short half-life from the gut, this is usually a minor contribution unless the intestinal damage is very acute and severe. Oh, and prolonged anorexia, especially in ponies and donkeys, that can definitely trigger hyperlipemia and associated liver changes like fatty infiltration, which then dries up ALP, often along with GGT. So yeah, it's a pretty wide net, but those are the main areas we investigate.
That's a really comprehensive picture. So when a vet gets that lab report back with a high ALP, it's clearly a clue, but how do they actually start piecing together the full story? What's the very first step in figuring out what's really going on with that horse?
Well, that's the real diagnostic challenge, isn't it? And it always starts with the horse itself, standing right there. First, we look for clinical signs. These are the direct results of whatever underlying disease is happening. Owners might report historical findings like icterus, that's the yellowing of the skin or eyes, or dark urine, maybe anorexia, weight loss, lethargy, or even behavioral changes if there's hepatic encephalopathy going on. Sometimes abdominal pain or colic can occur with acute liver conditions or biliary obstructions. Then, on the physical examination, we'd look carefully for those same signs. Icterus, changes in heart and respiratory rates, fever, photosensitization, that's increased sensitivity to sunlight, which can happen with liver damage, weight loss, or maybe obesity, which can point towards hyperlipemia. All these signs vary depending on what's actually causing the problem. When we're thinking about the differential diagnosis, we always keep in mind that increases caused primarily by bone ALP are mostly seen in growing animals, right? In adults, increased bone ALP is usually pretty mild and often associated with some kind of lameness or obvious bony issue. The really high elevations in ALP, those are generally associated with long-standing conditions involving severe cholestasis. So the actual magnitude of the increase gives us a clue. Also, if a horse has concurrent obesity and high enzyme concentrations, that points towards hyperlipemia or hepatic lipidosis, whereas anorexia and weight loss, those are more typical of most other liver disease possibilities.
That's a great framework for thinking about it. And as you said right at the beginning, ALP is rarely interpreted totally on its own. So once those initial observations are made, what are the crucial complementary tests that vets look at to really confirm suspicions or rule things out? It sounds like it's all about looking at the patterns across different tests.
Exactly. It really is like detective work. You're gathering more evidence. ALP is just one clue. We almost always look at it alongside other key tests. Gamma-glutamyl transferase, or GGT, is a big one. It's often more sensitive and more specific for biliary tract involvement and cholestasis. So if you see both GGT and ALP elevated, that strongly points towards hepatobiliary disease. Then there are sorbitol dehydrogenase, SDH, and glutamate dehydrogenase, GLDH. These are liver-specific enzymes that indicate acute hepatocellular damage to the liver cells themselves. Because they have a very short half-life, they reflect recent and ongoing liver cell injury. So putting it together, for example, if ALP and GGT are high, but SDH and GLDH are normal or only mildly elevated, it might suggest a more chronic or resolving liver issue, or perhaps just cholestasis without active cell death right now. But if all of them are high ALP, high GGT, very high SDH, GLDH, plus maybe high bilirubin and high bile acids, well, that pattern suggests acute and severe liver disease with significant cholestasis happening.
Okay, that pattern recognition is key. What else?
Well, we definitely look at bile acids. They're an excellent indicator of decreased liver function, especially with things like portosystemic shunts or actual liver failure. And they're often more sensitive than ALP for detecting cholestasis itself. Bilirubin levels, both conjugated and unconjugated forms, give clues about impaired bile flow versus maybe red blood cell destruction. Glucose levels can be revealing. You might see hyperglycemia after eating or hypoglycemia during fasting if there's significant hepatic insufficiency. A decrease in albumin production can be a late sign of hepatic insufficiency, although it can also decrease mildly just with inflammation. Blood urea nitrogen, BUN, can sometimes be decreased with hepatic insufficiency because the liver isn't converting ammonia to urea efficiently. Increased triglycerides obviously point towards hyperlipemia. And even a urinalysis can be helpful. Finding bilirubinuria indicates cholestasis. Finding ammonia urate crystals might suggest hepatic insufficiency or maybe a shunt.
Wow, there's a lot to look at beyond just the ALP.
There is. And beyond the routine blood work, we might use imaging, like ultrasonography, to actually look at the liver, its size, shape, position, the texture of the parenchyma. And sometimes more invasive procedures like aspiration cytology or a biopsy might be needed to get a definitive diagnosis of the liver condition. It's also really important to be aware that certain things can interfere with the test itself. Some drugs, like arsenate or zinc, might cause falsely low ALP values. And anticoagulants used in blood tubes, specifically complexing ones like citrate, EDTA, or oxalate, actually inhibit ALP activity, so you should not use those tubes if you're measuring ALP. Even things like extreme icterus in the sample, severe lipemia, fatty blood, marked hemolysis, broken red cells, or even just how the sample is stored can affect the final value. Oh, and a quick note on low ALP, it's much less common and honestly rarely clinically significant in horses. While there are some potential causes like severe malnutrition or zinc deficiency, a low ALP on its own usually isn't something we worry much about.
That's incredibly thorough. It really paints a picture of how vets use ALP as part of a much larger investigation. So, armed with all this diagnostic information, what does this actually mean for treatment? Is the goal just to give the horse something to lower its ALP number?
This is such a critical point, and it's a common misunderstanding, I think. The absolute core message here is that you do not treat the ALP level directly, ever. ALP is a diagnostic indicator. It's a clue. It is not the disease itself. It's exactly like a check engine light on your car. You don't treat the light, right? You figure out why the light is on and you fix the engine. So treatment focuses entirely on diagnosing and then treating the underlying cause of why the ALP is abnormal.
Okay, so fix the underlying problem, not the number. Makes sense.
Precisely. So for elevated ALP, if the cause is determined to be liver disease, the first step is always to try and identify and remove any triggering factor, like those hepatotoxic plants we mentioned, or maybe contaminated feed, or even a suspected medication. Supportive care is absolutely crucial. This usually involves things like a high carbohydrate, moderate protein diet, maybe avoiding excessive fat if there's significant cholestasis, and definitely fluid therapy to maintain hydration and perfusion. We might also use liver protectants and antioxidants, things like S-abanosilmethionine or semi-silmarin from milk thistle extract, vitamin E, vitamin C, B vitamins. Sometimes bile acid modulators like ursodeoxycholic acid or UDCA are considered to try and improve bile flow in those cholestatic conditions. And of course, we have to manage any complications that arise, like hepatic encephalopathy, often using medications like lactulose and specific oral antibiotics, or treating gastric ulcers, or managing photosensitization by keeping the horse out of direct sunlight. And naturally, specific treatments like antibiotics would be needed if there's a bacterial infection like cholangiohepatitis.
Okay, so that's for liver disease. What about the other causes?
Right. If the elevated ALP is traced back to gastrointestinal disease, the focus is entirely on treating that primary GI condition. Maybe it's an impaction or enteritis or parasitism or post-surgical complications. Treatment involves supportive care like fluid therapy, pain management, anti-inflammatories, maybe prokinetics depending on the issue. For bone disease causing high ALP, treatment involves things like nutritional correction, especially if there's a calcium-phosphorus imbalance, like in nutritional secondary hyperparathyroidism.
Well,
Also, pain management or specific fracture management if that's the cause. And this is really important for those falls with that physiologically elevated ALP due to normal growth. It's absolutely crucial to understand. No treatment is needed. None. Provided the foal is otherwise healthy, active, growing well, and all other relevant liver and bone parameters are normal. It's a completely normal finding, and trying to treat that number would be pointless and potentially harmful.
that's a really key takeaway for foal owners. Don't panic about the number alone if the foal looks great.
Exactly. And just briefly, for decreased ALP, again, it's rarely treated directly. We would only really intervene if severe nutritional deficiencies like protein or zinc deficiency were clearly identified as the cause.
That's a great distinction between treating the cause versus the number. So once treatment for the underlying condition is initiated, how do vets typically monitor progress? And what can owners generally expect regarding the horse's outcome or prognosis?
Monitoring progress usually involves serial blood tests. We'll recheck ALP, but also those associated enzymes like GGT, SDH, GLDH, and maybe bile acids over time. This helps us track the response to treatment and see if the underlying condition is actually resolving. We also, of course, closely monitor the horse's clinical signs. Are they improving? Is their appetite back? Energy levels better? Are specific signs like icterus or photosensitization resolving? That clinical picture is just as important as the numbers. As for prognosis, it's directly tied to the prognosis of the underlying condition causing the ALP change. Those physiologic elevations and foals, totally normal, excellent prognosis means nothing bad. Elevations due to acute treatable conditions like maybe an acute toxic liver injury where the toxin is successfully removed often resolve completely, and then ALP can return to the normal range. However, elevations due to chronic, often irreversible conditions like severe chronic liver fibrosis or cirrhosis, well, the ALP might remain elevated or only partially improve, indicating ongoing pathology. That obviously carries a more guarded long-term outlook. There are a couple of important prognostic indicators we watch for. Developing hypoglycemia, so very low blood sugar, or having ALP levels that remain consistently very high, say over 900 IUL. In a horse with known liver disease, those generally carry a more guarded prognosis. They suggest pretty significant liver compromise.
Got it. So as we wrap up this really informative deep dive, it's crystal clear that ALP is a valuable diagnostic marker in horses. But it's definitely non-specific, isn't it?
Yeah.
It's a key piece of information, absolutely. But its interpretation must always be done in the context of the horse's age, its specific clinical signs, and that complete biochemistry panel. It's really a team effort with all those different numbers and the horse itself.
Absolutely. I think the real power lies in understanding how all these different pieces of diagnostic information fit together, how they combine to tell a complete and often quite nuanced story about what's happening inside that horse's body. It really encourages us, vets and owners alike, to appreciate the complex, interconnected interplay of these biological markers.
So the next time you hear about an ALP level, whether it's for that young, fast-growing foal, or maybe an older horse with a bit of a mystery illness, hopefully, you'll understand that it's not just a number on a page. It's actually a crucial clue in a larger, fascinating biological puzzle, prompting us all to ask, okay, what hidden story is this number trying to tell us about the horse standing right in front of us?